Hi, everybody. Thank you so much for joining and happy Veterans Day. I know that a lot of folks are having a holiday, so a special thanks for joining us today as we are in remembrance of those who have served the country, but also having a very exciting fireside chat here. I am Michelle Berry. I'm the CEO and co-founder of CTI Africa, and we have our Life Health Passport. And we've also got Vima, which is our virtual intelligent medical assistant built on the Watson X AI platform. And with me, I've got Mr. Brendan Fowkes. Brendan, would you like to introduce yourself?
Yes, good afternoon, good morning, everyone, or folks listening in the evening. My name is Brendan Folks. I'm our global industry leader for healthcare from an IBM technology point of view. Been in healthcare about 30 years now. So really looking forward to a conversation today. Really excited about the partnership we have with CTI and how we work together as a team and try to, basically use AI for good.
Absolutely. Yeah, we are so excited too about the partnership and excited about the topic of the conversation. I think the format for this, we are loosely calling it a webinar, but the format for this is really more of a fireside chat. So we've got the dialogue box opened up on the chat side. So if folks have, pressing questions or want to dive a little deeper into any of the subjects that we bring up, by all means, just post it there. We'll try and keep a half an eye out for it along the way. And yeah, I just kind of want to dive in. I think that some of the things that Brendan and I had thought might be an interesting point to discuss is really this idea of AI for good. And what the heck does that mean? And especially in the world of healthcare, both of us have had different experiences in healthcare tech. I've been a provider at one point. I've been an assistant. I've been in the back of the office. I've been in the front in the exam rooms. And I'm also a medical anthropologist and sociocultural anthropologist. That's what I did my doctorate in. So I study systems. So I've looked at it from all these different perspectives of, the actual patient interface, being a patient and caring for those in my life, but also the provider interface, the facility interface, and then working with data my whole life, and especially health and wellness data, whether it's consumer data or patient type data. I think it's so fascinating to see how data in context is becoming a real point of concern and also a real point of opportunity. And then what do we do with AI? I think, AI is such a loose term these days, and I don't know that folks really know what to do with it. I know just on the basic consumer or patient side, there's a level of fear, that there's also a huge level of trust. And, what could AI do if it's channeled properly, if it's governed properly, and how do these things get stewarded in a way that's ethical, that's interoperable, and doesn't threaten folks, but actually invites them into to the possibilities and what's responsible in healthcare. So I'm hoping that framing it up that way gives us a chance just to dive in. So I'm kind of curious where you want to begin, or I could begin with, telling you a little bit about Life Health and the Life Health Passport, as well as my why. It's definitely related to veterans too.
Yeah, I think the other thing is we think about what we've done together as a group. As people think about this, and it's just framing it up a little bit, and I'm a little bit of a data governance fanatic. When we think about AI, there's a few components we're going to talk about. I want to make sure everyone level sets a little bit. AI requires data, and that data is either inside the walls of a hospital privately, or inside the walls of a government, a health plan here in the United States, whatever it may be. There's a data piece to it. There's a security piece to it. We're not going to scare anyone today about security. That's
Another
part of it.
webinar.
That's a whole nother. I have people, I'm actually in our Cambridge office on the security floor right now. So we have also, there is the buzz about models. You hear about OpenAI and Claude and all those things. That's also just a part of it. And
Mhm.
then what do you do with it? You want to take anything has to be agentic these days. So if you haven't heard the buzzword bingo, agentic AI for 2025, it's there. But how do you orchestrate all of this together and make sure it's governed? And when we say governed, that means it's meeting regulatory compliance, it's safe, it's ethical, it's fair, it's non-biased, especially in healthcare. So that's what we mean. We're going to use AI for good. All of those components roll in to start creating a non-mystery for it. So that's how we think about it. And then everything is tied to a use case. And the use cases are the fun stuff. There's no bad ideas. That's the fun part of when we started working together with the CTI team is like, could we? Maybe. Yes. Okay. Do we have the data? Is the data non-biased, etc.? So we went through this process. Every use case is a good one, and we do a little bit of a feasibility assessment of what might be a bridge too far to start, and then basically evolve into actually incremental value. That's the whole point of using AI efficiently in an organization. That's sort of the starting point for the conversation. I think it would be great is I think you could talk a little bit more about what you guys have already done because it's really exciting. And I think we can really start to frame that into making sure everyone also understands AI is not here to take your job, it's here to help you. And then the other piece is where we could potentially use that, for example, our veterans community, since it is
Mm-hmm.
Veterans Day.
Mm-hmm.
So I think a
Yeah,
little bit about, your the assistant and your passport is great.
sounds perfect. And thanks for the grounding. I think that as a partner to IBM, that's exactly why we chose you. We wanted to make sure that we were coming in grounded, that we understood the guardrails, that we understood what best in class looks like, and it is a complicated space that we're in. And so I think giving you a little bit of history about our company. Our company actually started overseas, and we started in Africa. And the whole reason that we began is that patients didn't have any access to anything. Medical records, even written, were not something that were available or was available. So it started off a bit as a humanitarian exercise to make sure that people just had the most basic health equity, most basic health access. So in that environment, we don't have the same fragmented or disconnected systems that we do here in the United States in our own backyard. So it was easier for us in some ways to start from literally a blank slate or an empty canvas and think about what would be the optimal patient experience. How do you get your records? How do you organize them? How do you access them? How do you make it culturally responsive? How do you transfer them? When you are in a borderless system and you're moving in between spaces or you have a transient lifestyle, how do you take these things with you and produce them at a time of need and be able to share those and revoke those, under your own free will? And so over time, after we had launched in Africa, we serendipitously came to the United States. And what we realized is that we've got our own similar situations here in our own backyard. I think there's times where we think we're in control, but we're not. Most of us, have some level of access to medical records, whether that's through some of the major systems like Epic or Cerner or the VA. But at the end of the day, most people have about 95% of their life outside of those institutions or facilities is where they're spending their time taking care of their health and wellness. And most are also experimenting or using out-of-network providers, even basic things like dental health records that aren't even captured in the existing systems are part of one's ecosystem and how they take care of their health and wellness. So here in the US, as we're looking at what it looks like here, we developed what we called the LifeHealth Passport. And so that is our app. And inside that app, we've created a healthcare ecosystem that's really patient-centered. I mean, in the most intimate way. The whole goal is to enable the patient not only to download their records into their digital health ecosystem, into their passport, but it also provides an opportunity for them to upload. So I don't know, like my son had a ER visit and an urgent care visit that was out of network for where I normally can access his medical records just a couple weeks ago. And I left with papers. It was old school paperwork that had the medications and it had the diagnosis and the scans and the labs, all the things that they did while he was there. This system actually enables me to take those records myself and I will upload those and make sure that they are in the ecosystem of his overall healthcare. So we can download from the systems that exist. We can also upload on our own terms, and we can upload anything we want. We can upload scans, medications, labs, soap notes, whatever we're armed with, all goes into that same feed and that same data set. In addition to that, we've got telehealth. So we've got mental health, we've got dental health, and we've got primary care, which is a very rare combination to have all three. And especially when you're working in kind of an ecosystem fashion, to have all that data. Those are all different touch points of who we are and what our real health status is. And we also have an e-commerce component that allows patients to get lower cost prescriptions, over the counter, supplements and drugs that can be basically considered in context of their healthcare to create some bundled health solutions to make it easier and accessible and affordable. And then lastly, we've got some fantastic remote patient monitoring device capabilities, and all of these are integrated. So everything from health records to biometrics to consumer behavior and some, even determinants, social determinants are all now in one place, and they're mine and they're yours, and you can add your family members. So the whole goal of this for us was about extending the continuity of care, but more importantly, reinforcing how we take care of ourselves and our families and our loved ones under our own roofs. Because I don't know about you, but the technology over the last 6 months has just gone wild. It's just moved at such a quick clip that we really can take care of ourselves under our own roofs in ways that we never could have possibly have done that before. So that's a bit
And I,
about the system.
yeah, and I think it was really interesting, and that's, one of the things obviously that we've come together over a while is initially we had that blank canvas, as you said, in Africa, and it was that idea that no one's putting up telephone poles, everybody went to cell phones. Why create an incremental step when you don't have to?
Mhm.
And I think we're starting to come back here on this side. And I think what's really important, that idea of health and wellness and taking care of yourself, is right now there's an innovation opportunity in the market that I see. I see it around the world, but also right now because this is a unique time in our industry where there's some regulations about sharing data that are a good thing, finally, in the right direction. And at the same time, the financial model is slightly imploding on itself. So
Mhm.
the openness to innovate and drive down cost of care, drive down overall expenses in the need for affordability in the system is massive, not just for those who need it most, but for the insured population also. Because I was driving in here to the office this morning, I was listening to Bloomberg News, and they started to talk about the healthcare economy. Like, these are the people on Bloomberg surveillance in the morning. They know everything about the financial economy. And there was four of them that said, I don't know how the healthcare economy actually works, because I realized during open enrollment, I'm going to pay almost $7,000 myself for my benefits. I'm
Mhm.
saying this publicly on the news. And I thought it was like a 50-50 split. No, my employer is paying 20,000.
Yeah.
And then I pay 7 on top of that.
Mhm.
They're like, how is that $27,000 in employee? Bloomberg employs probably a few people. So you'd think they'd be getting a good deal on that overall health
Right.
and
Volume
wellness.
discount.
They get some sort of volume discount, but it's one of those things, whether it's a health plan, a self-insured employer like IBM is, a self-funded insurer like IBM is, we just have other people process the work for us, or Bloomberg or any of this, it all needs to sort of come together right now because this model is at a scale that it can't keep growing. So these
Mhm.
innovative ideas of where we can help and where we can help those that need it most, because that's going to deliver cost value for everyone in the market. Everyone in the industry benefits if we can
Absolutely.
care for the people that need it most.
I couldn't agree more. And I think that's the area too that, we're hyper focused on is these underserved communities. And, some people have pushed back and said, well, how's that a business model? Like it's so niche. And I'm like, it's actually not. The most of the United States is an underserved community. If you start really looking what that means, in the context of elderly living at home, folks who are disabled, anybody who is lower income, rural, to add it up, the reality is that people can't afford to keep doing it the way that we have been doing it, not just financially, but I think also culturally and ethically. I mean, there's a lot of folks that have been left behind. And, like we were saying, even about the veterans, it's one of the most complex communities to serve and deliver healthcare effectively to. Everything from, not having access to records to states having, different opt-in or opt-outs for their HIE programs. I mean, there's so many layers from even from state to state that it makes it really challenging. So I think what we're trying to do is really bring in that empowerment model so that it is borderless, the patient is in control. And you know what? I own my records for the first time. I don't have to go ask permission any longer for someone else to please give me my records, fax them, send them to me on a floppy disk. I still am getting those kinds of things now. It is not realistic. And it
Yeah,
makes it
and
very
the other thing,
difficult to care for yourself.
and for the veterans, on this type of day, there's a lot of veterans where the closest veterans VA system is 5 hours, 6 hours. In
Yeah.
Boston, we have two. We're spoiled, along with all the other healthcare. In certain pockets of the country, there is access, even if it's delayed sometimes, it's still access, versus it takes a day and a half to do something. And I think that's where this type of innovation and working with organizations like potentially like the Innovation Center within the veterans or the individual visits is an opportunity to deliver care where they need it. The
Mhm.
veterans that live in rural North Dakota, rural
Yeah,
Oklahoma, pick a spot.
absolutely.
The
Even where
mountains,
they
the
are.
beautiful mountains of Colorado, things along those lines, wherever they need that ability to connect, because there tends to be internet connectivity, unless you go to the desert to look for horses. That's a common inside joke for everybody there. Um, but along the way, you can find something or the ability to connect and talk to another human being in the way that you want to. And
Yeah.
I think that's where the innovation has to come, because
Hmm.
it's that experience, the access, the experience. We can use the quadruple aim over and over again. But that's going to drive down the cost with a better experience and access to care. And that's just going to deliver better outcomes. That's how it's supposed to be working.
Hmm.
That's the interesting thing. The ability to adapt, I think this is nice, which has been working with you over the years, is whether it's here or all of a sudden potential pilots on a particular type of care in the NHS. So we're talking about not just the US system, we're talking to folks in the UK system, because you came out of that. It really has a global view and taking the best ideas from everybody
Hmm.
and how we can adapt them and then deliver what matters most to the people that need it most, and then go from there. So I
Yeah.
think that's been a great journey so far, and when you're really just getting started.
We are just getting started. And I think, client zero, here we are. Let's go. We are just launching and in the US, and we've got some great pilots that, are there. And what I'm finding is that some businesses you're kind of selling a widget, and you've got a very specific kind of narrow target audience, and you've got one group that you're serving, and so it's sort of it's a straight line. Ours is not a straight line because we are touching the patient, we're touching the provider. I mean, using our ecosystem, whether you're a home health care provider or you are a community health worker or a visiting nurse, for example, we can be saving that person, 2 hours of intake and documentation time and drop it down to 20 minutes, and just in that amount of time, imagine what kind of care they could be doing and how many more people they could be touching, especially when we're in a place in time right now where there just are not enough nurses. There are not enough doctors. Hospitals are closing down around our country left and right. So how do we not only save time and not take the jobs, kind of to what we were saying before, is AI coming from my job? We hear that a lot, especially in emerging nations, or in, I think, professions that maybe don't feel quite as secure, where they, are not in facility and they're doing more home health care work. I think it's a big concern. And also, what's the benefit of going through the learning curve of figuring out how to use AI? And then also, is it okay if it fails? Is it okay if it doesn't go well? And I think, a lot of the focus right now on organizations that are trying to bring AI in are thinking, oh, it's all the big guys with the big budgets that are going to, kill it on the AI and they're going to be able to, scale it quickly. I'm not sure that that's the case. I think it actually might be the smaller, leaner companies, kind of like ourselves, that are going to go out and we're going to pressure test it. We're going to fail. We're going to learn quickly, and we're going to, keep evolving it and creating a new way for folks to learn it who aren't necessarily, PhDs or MDs or RNs or whatever. I mean, these are folks that are truly doing community-based care. But I also want to be able to figure out how to use it myself. If I'm caring for my mom who lives 40 minutes away from me, she might as well be in another country at times. And, do I have her medication list that's current? No. Do I have her medical records or her last, blood pressure, check that she did with her, blood pressure jumping around? No. But I'm her POA. So I'm supposed to make these life and death decisions if she has an emergency or needs to be admitted or she's traveling on a cruise or whatever, how do I do that? So we're trying to simplify it to the point that almost anyone can experience this and partake in caregiving, expand the caregiving community far beyond what we have today. And that's how the model works in other countries. There are millions of community healthcare and village healthcare workers, in places like Africa. We just don't have that here. I mean, we've got little pockets of it, but not the volume and not the organized approach. And so I think we're trying to streamline that.
Yeah,
And the
and
AI
I
is the
think that
help, right? The AI is the
yeah,
helper. It's automating the stuff we don't want to do so that we can actually give better care. So it's like it's outsourcing the garbage. I almost said a
yeah.
bad word.
And I think a comment I heard the other day was from one of our execs, nothing to do with healthcare, and he was saying, "Listen, we want to automate the mundane and augment the complex."
Yes,
Back
beautifully
to,
said.
but I think there is a disconnect in organizations sometimes, whether it's a community health organization or a large, giant, integrated delivery network or a community, whatever it may be, or a health plan or anywhere. Is AI coming for my job? Because you
Mhm.
hear execs around the world saying AI is going to revolutionize our business in every other industry, not, whether it's tech or finance and this and that. We're going to have to right size the job role. So people get nervous, and that happens in every company. But I think it's one of those things. It's an education that needs to happen in a lot of organizations, and that's a lot of times what we end up doing. People, so you start talking to the executives. Say, do you think your team has a clear vision of how you want to use AI? And of course, the execs will say, "Of course we do." You get down to that mid-level, lower level management and the doers every day, and it's not there's a massive disconnect there. And there
Yeah.
was a survey from the company Superintelligence that went through that. Also, one of these guys has an AI podcast every day, and he talked about the disconnect. And I thought it was a really unique thing. It's one of those things that listen to AI podcasts when I'm traveling on planes. Why not? So it catch up on them,
We have
but it
something
is that
shared in common. I tend to do the
yes,
same. What else are
yeah,
you going to do?
yeah. I don't know. Work, watch
Either I'm
TV.
using
Always
AI
be
to do my work or I'm listening to
yeah.
it.
But I think it's an understanding. I think having people understand back to the use case. People that do the mundane and want to do more, they want to do more. People want to do value added work and feel like they did something at the end of the day. They generally have the best ideas for use cases
Hmm.
that can drive the most ROI because it can just take
Yes.
so many hours out of the system. As you said, the ability to go from 2 hours of intake to 20 minutes. Now that's a
Hmm.
real use case. I think, companies like a bridge that's out there in big hospital systems about ambient listening. Oh my God, that is a burnout. Why have we waited so long to do that? Nuance does it with Microsoft. There's a lot of people doing. We don't. There's a lot of people doing it successfully. For big
Mhm.
systems, that's a huge cost savings. Now it comes at a price, but the cost of a nursing turnover is about $52,000 a nurse. So if your nurse is burnt out and leaves and decides to go work for pharma and sell drugs instead, it takes $52,000 to get one of them back, and it's
Mhm.
about 22.7% turnover rate average. in most healthcare systems here in the US. And
Mhm.
friends of ours in New York, they said, I quoted 52, the study. And he's like, that's the right number, but in New York, it's more like 65
I bet. Yeah.
to get a nurse back in the door. So anything but your home health, your community, your hospice nurses, those VNA, like there's a population there that we have the ability to get to because we know the work we've done together. The data's fair. It's not biased. It's trusted. It's explainable. Why did you get, a lot of time if we dig in, you can click, we have a lot of UIs that we then take away because it just run. We just hit show reasoning. How did I get to this answer? And the always human in the loop doesn't like it. They then obviously do the change it, but then that feedback loop is in there. And that's part of the work that we've cultivated, especially with some of the early work with the medical assistant that we didn't even get to. We were so focused on the
Let's get to
passport.
that. Let's make sure
Yeah,
we talk about Vima. Yeah.
that's where I was setting it up for Vima, but
Thank you.
it's
Beautiful.
about helping the workers and the patients
Yeah.
because you know where the answer came from. You can trust the answer. And as a layperson, you can ask a question about what this means. And we know we've curated it well enough together that it's safe
Mhm.
enough to put the questions out there.
Yeah, beautifully said. Yeah, so those who might be new to this, Vima is what we call it, but it's the virtual intelligent medical assistant. And the reason that we think Vima is incredibly powerful is that all the data that we're collecting about you is about you. And it's completely in context and it's pretty holistic data about what's going on in your world. When all that data is there and it's secure, Vima has the ability to not only hyper personalize the information that's coming back to you, but I think it automatically increases the level of trust in people wanting to use AI. It's one thing to go out into open or cloud and say, look, I or my son or my mother or whatever has all these symptoms, and you list them and you try to remember every single thing that's happened in the last however long you can remember it. But it's all about our memories, which are completely faulty, especially mine. And so, if you start thinking about, yeah, what actually happened, do you remember what drugs you're on? I honestly don't even know sometimes, like, I don't even know what the dosage is on what I take right now on one drug, right? So the point being is all that information is in context. So I'm not going out and getting an aggregate of what is going on out in the ecosystem and it's trying to sort of carve it down. It's actually about me. And we've asked people, would you be more apt to trust someone hunting through all of your different medical records and all your papers and your different things, or would you rather have everything aggregated? And would you trust AI to understand that information in context and then be able to give you something that is a pretty darn good assessment or a summary or a drug interaction or alert or things that could literally save your life? Would you trust that? And people are increasingly more comfortable in trusting AI. I think there's some generational differences for sure, but even demonstrating that with I've got an 88-year-old stage 4 cancer relative that I'm, working with, and trying to support her care in hospice. And we started talking about AI. She says, I don't want any of that. Keep it out of my life. It's dangerous. It's going to use it against me, and all of these things. But then when I started showing her, look, I've got all your medical records here. I've got all your medications, and they're the right ones. And we used the information when she was, taken to the hospital out of network, and they were going to hold her for an extra 24 hours because they could not reconcile her medications and she wanted to go home. So there's all these different ways to use it, but I think the trust is building, the credibility is building, the infrastructure and all the security that we work with you all on puts it into a context where there is a real trust. I also strongly believe that it's about the people behind it. More often than not, people want to know who's accessing, who can see it, where does it come from, and also AI right now is trying to figure out how to be empathetic. I think that might be the next horizon. Right now it's easy enough to do a quick summary or flag or remind somebody because those are the tasks that you mentioned. But where is the room for empathy? And where's the room for encouragement, for understanding fear, for giving people a nudge? So being a bit more of an advocate and a bit more of a companion as opposed to just being a yet another task manager. And I think that there's some really interesting space for innovation there, especially in healthcare, because that is also where a lot of that burnout comes from that you were saying. It's the menial tasks, but it's also the emotional energy that folks have to put forward in order to have someone feel heard or seen.
Yeah, I think the other thing too is that point about the aggregate of your data and asking the right questions. That's
Mhm.
one of the things, as someone who advocates for my own health and my family's, et cetera, we've all had to do the advocacy. What's the right question to ask? And I'm not going to get into a prompt engineering conversation today.
Good.
But
That
if you
wouldn't be
don't
my
have,
bailiwick.
yeah, I got it. But that's part of the data point of it. And I remember I thought of it as when we were prepping for this, I didn't even think of the scenario, but the way you just phrased it, I remember sitting, and it wasn't in one of my appointments, but I was somewhere else, and there was a doctor. He had a coffee mug, and when he picked it up, it said, "My medical degree is smarter than your Google search," in big, huge letters. And it was interesting because
That
that's
was the
we would
time.
joke for years. People would go and do Dr. Google. We used to cope. We've all done it.
Yeah.
Guilty as charged.
Many, many times. Many
And,
times.
and you know, whether it's Gemini, the MedPalm, or the work you can do with Claude, with Anthropic, they're very smart. Those things are very well trained. They've
Mhm.
trained themselves on basically everything there is to train themselves on,
Yeah.
but they don't know you. And
Nope.
they know you might not know exactly what question to ask or ask the question correctly. But if you use it in Vima, it knows enough about you that when you ask the question, the additional information is there to help explain how it got to an answer. If I
Bingo.
just say, hey, my red blood count's low, Google's going to tell me I'm anemic and I should do something.
Hmm.
I don't know if that really is any symptom of anything, because if I just ask the question from that point, and it's really about how do we get to that and the data behind it. I got a question from somebody in the chat.
Says, thanks, Michelle, for that insight. What I've experienced about AI is that everyone is starting to trust AI, just like you said, but AI in some cases doesn't conclude completely its recommendation, and it will conclude by a physical contact with physician or medical professional. Yeah, great point, well taken. Yeah, I mean, it can't live alone. It's not displacing the need to speak to a professional. I mean, we always have to be clear on that. It's not diagnosing, and it's not ever going to be in that, most likely. I mean, the whole role of it is it's meant to provide information, summarize, trying to make sense of things in context, and then give you some ideas or prompts or referrals. It's meant to be a thinking support mechanism,
So
more than anything,
almost like
right?
a
So,
lot of times we try to use that as like a coach, a
yeah,
wellness coach,
a
a health
wellness
coach,
coach, yeah, an
health coach.
advocate. It's like, just, hey, did you think about this, or did you see this, did you notice that? So that's a great point. It's never going to displace the human. The goal is
Yes.
that once you have to go from your home environment or wherever you are, and you do need to get to that urgent care clinic or the ER or your next doctor's visit or your next infusion, whatever it is, that you're coming in with information that you've never had at your fingertips before, and you are in control to come in and share it on live on site with your phone to somebody sitting across from you, and they can very quickly get an assessment of what is going on with this person, what is their history, what might we be looking at, and real information in real time, credible and validated information. And that's new. We have not had this before. I mean, when my dad had pancreatic cancer, he was diagnosed March 2020, like right when the shutdown happened. And he was stage 4, and he saw 23 providers over 13 facilities in a 1 year period. And I was his POA, and of course, being working in healthcare, I was, all over it, trying to figure out how to manage it and save his life. But we were compiling documents and Excel spreadsheets and sending emails and trying to fax things and all these things. It was hours and hours and hours of fragmented, disconnected pieces of information. And even we didn't know real time what was really going on, especially when his vitals were changing daily. His blood pressure was jumping around, his blood sugar was jumping around, his oxygen was jumping around, everything was changing. We did not have 24 our access to care at 2 in the morning when things got dicey, or who to even consult with, or what to share. And every time we went somewhere, we had to start from scratch. When he felt horrible, we were upset, and we'd spend hours doing intakes and starting everything over from the very beginning. So it's like if we would have had Life Health during that time, we could have been not only better managing his care, him and I together, but getting that information to his care providers in a fashion that they could recognize quickly, and they could trust also. And then on top of that, we wouldn't have been spending our time sitting next to each other building Excel spreadsheets. Not that I'm complaining. I would spend any time with them that I could have at that time, but we would have been spending our time doing something much more meaningful. It wouldn't have been that. And so that's also, part of my why. But if I can tell that use case, and know that his records were everywhere from the VA to Epic to naturopaths, chiropractors, acupuncturists. He had 100 medications and over-the-counter supplements and whatnot in that 1 year period. I am not the only person that has that story. There are millions. Most people I even utter those words to, they're like, oh, yeah, I had this kind of similar thing with my mom or my dad or my friend or my child, and so I think for us, what we're trying to orchestrate is not only how we understand what's going on with our loved ones, but how we can transfer that information quickly anywhere in the world without borders. And that's why we call it a passport. It's literally meant to be a borderless system to invite you to explore some new things in your own world, but also give you access. So that's the thing.
And it's interesting too, and Michael made a point, another really good one is,
Okay.
it's the other thing, back to starting with that blank slate. And I always would coin the term, and I don't know who created it, it's not me, but you can't fix what you can't measure.
Absolutely.
And having now that recorded history of what was done in where you started is huge, because now you can start to study disease patterns or outbreaks and things like that, or basic dietary needs.
Mm-hmm.
What seems to be the problem? Why are these people, everyone seems to be, you have an inkling of where a malnourished, a food desert is, but you didn't have the data on it. Now, if there's a data on it, then you say, okay, they actually just need more grain. They can make bread through this drought. And now you can then measure the quality of life, better disease, all these things. And that's the other thing too, back to orchestrating the whole person care is, we keep saying the people that need it the most. How do we get care to the people that need it the most? And back to your opening statement about, you're not just an episode of care, you're not an acute care episode. The majority of your life is spent outside the walls of either a primary care, a telehealth visit, or God forbid, a full acute visit. What you do outside of that, orchestrating that, it still needs to be fixed and measured. We went from food desert to a few weeks ago. Hopefully that's going to fix this week. I'm supposed to fly
Yeah,
later this week. This should be interesting.
I hope so.
Um,
Yeah, that's
so that just
new
another
crisis.
challenge of how do we make sure that people get the food, the health, and those coaching to get it there. Is it a business model? Probably. We're getting to that point, but there's something there, because I think now we're at a point and a need where years ago, there's like, oh, this it's going to be the consumerism of healthcare in America. That was
Mm-hmm. Yeah, I remember
one of
that.
these
I
strategy
remember that chant.
consultants. That was the chant. All the strategy
Yeah,
consultants were then running around doing multi-million-dollar engagements for all these hospitals of how they were going to become
yeah.
consumer behavior.
I
It's
was
going to
gonna
be like
say that was my
Amazon,
heyday of research with consumer behavior. It's a
consumerism in
decade of
healthcare.
it, right? Exactly.
But the consumers weren't there. Um, I think the consumer demand, it's also, I think it's a demographic. You studied the system of systems, so I'm not going to even pretend to delve into your background, your doctorate. But I think there's a generational acceptance of, this is unacceptable, and how do I get something better? As
Mhm.
people start to demand that a little bit more, our generation starts to move. I'm one of these over 50-year-old white guys now. So I understand technology. I'm going to demand that level of intimacy from whether my provider, my health plan, whatever it may be going forward, because I understand it and I want it. I think
Mhm.
that's going to help move and drive some of the business model. And there will
Yeah.
be proof points along the way that we drive cost, which works, which will work and improve outcomes. That will work and help really affect systemic change here in the US.
Mhm.
I think the other countries, they just have to figure out where it fits into their sort of strategy. I think sometimes the government funded healthcare systems, whether it's the NHS or France or things like that, whatever it might be, other places, there's a great opportunity also because you can prove it and then roll it out.
Yeah.
And
Well,
once you prove it, it
the
rolls
opportunity
out
is
and
even
everyone's
bigger.
excited. The US becomes a whole nother political debate of, okay, we proved it, we rolled it out, and a federally qualified healthcare center and their failing doctors are using it and they're getting great results. And then you have to go prove it again and again and again
Again
and
and
again. A
again
little
and
bit,
again.
sometimes, a system as special as the NHS is, and they have their own unique environment, I'll put it
Absolutely.
politely, there's
Absolutely.
still that momentum that can build and then it can just roll out. You generally have to prove it again, but there's just so much opportunity to just orchestrate that person. That's why we're really excited to be working together.
I know. Likewise, I think, and what we're talking about here is we're having I think more of an added emphasis on the U.S. market, and that's
Mhm.
something that we can relate to, and probably a lot of people who are, listening in. I know there's some that are not from the U.S., but the U.S. is more. There is a defined underserved community that's large, and it seems to be getting larger. So there is the need, but there's also the need not just to have the underserved health, basic health equity and access needs met, but also the ability to create a very premium self-care experience, right? So we can go all sorts of ways and have all these different added value, but when you really look at global markets and you're looking at places like Africa, there isn't anything there. So you truly are coming in and building best in class technology. And in Africa, we don't just use Life Health Passport. We actually have, a full EMR. We've got a full hospital, facility, system. So we report into government infrastructures as well. So you're getting into things that are not just solving the patient gap, but we are quite literally dropping in a plug and play infrastructure where nothing exists, not a thing, or we are bookending or kind of mixing and matching modules with, things that are just getting started. But the ability for those markets to not only quickly dive in and understand an optimized version of what it should look like, but for them to be able to leapfrog in more legacy systems in industrialized nations is very real. So I mean, my prediction is places like Africa are going to have a rip roaring time of medical and tourism because they're going to have these systems and best in class technologies, best in class new devices, best in class integrations. They're going to have things that we struggle to do here for a variety of reasons. So it'll be interesting to see how it works, but
And
the needs
I
are
think,
the same, but they're also quite different.
but I think that's an interesting point of view because a lot of times, as you traveled around, I've traveled around, others. A lot of times, there's people set up, but because the UK is paying more, because the UK needs people, because the US has recruited the nurses from the UK, and then they're going to have such a better experience with some of these other things that they may not leave. A better experience for a clinician means the world for helping patients.
Mhm.
And then you can be able to help from there. And I think that's one of those interesting things. And it's funny, I just looked up and realized we just went through 50 minutes.
I know that it always goes too fast. Like
Yeah, we were
there's
having a
so
conversation
many
during setup.
problems in the world.
No, but it was funny. We're like, oh yeah, we'll go for
Just
like
scratch
30,
the
35
surface.
minutes and
I
let
know, just
everyone give
scratch
them
the
a 20.
surface.
Yeah.
So here, there is a question in here too. It
There's
says
another comment.
in the U.S. you hinge on the security numbers, but here in Africa we have the national ID. All human activities be it health, business, trade, whatever data should be implemented here. IBM for data centers here.
So we're not going to have a national ID debate on this. We don't have enough time
I was
to
trying
get
to
into
figure out
that discussion.
how do we want to
Nope,
talk about that?
we're not going to
Let's
actually.
that
That's
will be
not a good way to.
webinar, the next
That is a
webinar,
that
phase
is one.
two.
That is one for the folks in Washington D.C. They will probably never agree on what to do there. So we're not going to leave on that note. I'll
We'll
get
let
closed
that
up
one
on that
sit for
note.
today.
Yeah, we'll
Well, I
let that one
think
sit for today. I think it's just been a really exciting, and I'll hand it to you to close. It's just like I said, we're just getting started. This
agreed.
is the opportunities are endless. There are, like I said, there's no bad use cases.
No.
If you have an idea, we'd love to hear about it. There's a chance that we may have done something already in our partnership that you could leverage and go, or you may have an idea that we didn't think of yet because there's, like you said, there's just so many challenges. We would love to um, see what's coming up next. So
Yeah.
please let you close. This was such a great discussion. Thank you so much for having me.
So great talking with you as always, and I appreciate the alignment and also just the real chance for real innovation at the I think we're at the right time at the right place to really move something forward in a meaningful fashion. And there was some things that we've all been talking about, but I think that it's about AI, not about what's possible always, but it's about what's being responsible. And that's, I think, where we're trying to, the next version and the innovations are probably going to hinge a lot on responsible innovation in the world of healthcare with AI. So we know we're in good hands and good partnership with you guys. And thanks for all the questions and comments in the chat. I'm sorry if we didn't get to all of them today, but you know how to find us. Look for either of us on LinkedIn, and
Yeah,
we can continue the conversation there. And we'll figure out how to post this for those who weren't able to join us in person. But thank you, Brendan. Happy
my
Veterans Day.
that's for all the veterans out there. If you listen to the recording of this, thank you for all your service and
Yes.
thank you for having me. What a pleasure. Great conversation as always.
Yeah, you too. Talk to you soon. Thanks, everybody.